Well, the topic I was asked to talk about was sort of oral pathology of mucous membranes. And that's a pretty broad topic, so I guess I could have picked anything I wanted. What I decided to do is tomorrow I'll talk about blisters and viral entities, and today we'll talk about just some of the more common entities that we run into in our lives. I'm not sure about Guatemala. I would assume it's the same as in the States, and that is that oral pathology is never, oral medicine is never or for very few people, is a money-making proposition. And you really have to learn the material, not because you are going to be earning a living from it, but because that gives you that special edge with your patient. You can treat them, as was mentioned earlier, as a physician of the oral cavity. You know more than just working on teeth. And that is not in any way to diminish the quality of working on teeth. But this is the rest of the story in the United States. We have come to appreciate oral pathology to keep the lawyers off of our doors, away from our doors, because the largest lawsuits in America come from missing diagnoses in the oral medicine, oral pathology world. So I know you don't have nearly as many lawyers as we have, but it's more important, I think, to know this material because you want to be a better dentist, and that means an oral medicine physician. Well, the main role of dentistry as far as oral pathology goes, if you look at our research, if you look at the talks that people give, has to do pretty much with cancer. And let me tell you, just to get started here, I'm going to be wandering around. This is more of what we call a continuing education seminar than a lecture. But the topics that we deal with have to do with really the things that look very innocuous in oral pathology in the mouth, but can lead to something very, very serious or be a sign of something very, very serious. I've diagnosed many, many anemias. Just before I left to come down here, I diagnosed a leukemic patient that was previously undiagnosed. He didn't know he had a problem. So it's just the life of an oral pathologist. But I was, for about 3 years after I quit the university life my first time in '94, I was asked to become the director, the dental director for our State Bureau for Public Health. And they were in a bit of trouble, and they just wanted somebody to kind of be a cheerleader and inspire all the dentists around the state who were helping the poor people in the state. And I did that, but that also gave me access to the tumor registry. And I knew, because of that experience and my experience in the medical school as the head and neck pathology person for the ENT department, I had records of oral cancers. And I knew from my own biopsy service, it covered the entire state of West Virginia. Nobody sent tissue outside our state. I knew that the average oral cancer that was sent to us from the dental profession was 1.4 centimeters in size. That is where we want to be. That's what the dental profession is shooting for. The medical profession, I knew from my work with the ENT people, the average size for those people was 4.4 centimeters. So dentistry is doing its job, even in a poor state like West Virginia. But on the other hand, when I got to be the dental director, I saw that dentistry was only diagnosing 10% of the oral cancers. So we can do that job, it's just that we're not doing it to enough people. And our role is to identify lesions very early, as this oral floor lesion is, rather than making it something of this nature. And since we are such a legal country, have become a legal country over the past 3 decades, this is something that this has caused some considerable concern in our country. Dentists doing lots of tooth work and ignoring lesions that are ulcers or masses in the mouth. This, for example, is a patient. The dentist lost his license and was sued very much by the estate of the family very heavily. But he put in about $30,000 US worth of aesthetic cosmetic dentistry, crown and bridge work essentially, and some partial work. And all the time just ignoring this festering tissue that he thought was just a little bit of inflammation. So he delayed the diagnosis for 2 years while he kept cutting crowns. And this is an orthodontist The patient kept coming in saying, I don't know if you can see, there's an impression in the Hawley retainer. The patient had 4 of those retainers, and they all showed a bigger and bigger mass developing. And the orthodontist never saw this patient. And there's another dentist who lost his license because of this. One of the problems we have, and actually it's not just a problem, I look at it as a real opportunity, is we're seen as dermatologists. Because of the quality of dental chairs nowadays, we are supposed to be seeing the mucous membrane of the oral area every bit as well as a dermatologist can see skin. That's the standard in our country anyway. So since oral cancers are primarily on the surface, and actually a lot of oral pathology is on the surface of the mucous membranes, we really shouldn't be missing too much. And one of the things that I mentioned, I'm clinically oriented as well as bench pathology, microscopically oriented. And all my life, I've thought that the clinical work was much more interesting. It is, as I mentioned earlier to somebody, it's detective work. I've got to know exactly what questions to ask. It's sort of like CSI work instead of just memorizing what every kind of tissue looks like under the microscope. So it's a lot more fun, and that's really the world that a general dentist or a specialist, clinical specialist lives in. So keep that in mind. And oral pathology has always dealt with this, Muir's law. When we try to pick out anything by itself, we find it hitched to everything else in the universe. I went through our textbook when we first were putting it together in the early 90s, and all of us had to review each other's chapters. That's one thing I think that made it better than it would have been. But in that process, I was just kind of keeping a mental a tab in my mind. How many of these lesions do we know the cause of, the exact cause? And I estimate that we have less than 10% of the things that we know of as diseases in the oral cavity where we know the real cause. We have guesses, but they're only guesses. There is no proof. And the other thing is how many of these are related to something outside the mouth, and that was about 20%. So at least in our textbook, 20% of all those lesions have something to do with something outside the mouth. What you see in the mouth might be a little bony bump, but the patient's disease might be Gardner's syndrome, where this little kid is going to get intestinal cancer by the age of 20 or 25. And the very first sign of that disease is a little bony bump in the oral cavity on the jaws. So that's where oral pathology has been coming from for a long, long time. But I don't want to ignore the teeth, but you get plenty of information about the teeth. Well, how do we learn about this kind of stuff? One of the things that is real important is to know exactly everything you can know about those things that are really common. In oral path, we have 2 kinds of people. We have the teachers we're talking about. We have the teachers who think that students can only handle 50 lesions. So teach them 50 lesions and really expect them to know those. I'm not in that camp. There's the other that think that students ought to be able to know 400 or 500 lesions and know them all pretty well. And for those who who teach the 50 lesions, I've made this list for them. It was my master's thesis. It is still the standard prevalence study for oral lesions in America and in Europe and in Canada. But it's a listing of all lesions found in about 24,000 adult mouths. These are Minnesotans, so it'd be a little different from Guatemala, I would imagine. But still, fairly close. How many people have irritation fibromas? How many people have canker sores? How many people have leukoplakia? This was the study that first answered those questions. And the prevalence is available in about per 1,000, so these numbers aren't percentages, they're per 1,000. And you can see the very first one. These are volunteer clinics from 17 little towns in Minnesota, and the very first, most common lesion was a white patch in the mouth, leukoplakia. And leukoplakia is one of the most studied, intriguing, dangerous types of lesions that we have in oral pathology. And because of that one entity, we really have a lot to talk about in this specialty. This was an entity this is a listing that I've been asked to talk about quite frequently. Actually, in Canada and Europe, another South American country, not another, but a South American country, that those are the kinds of things they want to talk about. The dentists don't want to, or let me put it the other way. The dentists in those areas want to make sure they know those 50 lesions. So what I've done is we'll just start with these entities and give it a little bit of a look. I want to point out one thing that I have made available to really the whole world for years now, and I'll tell you a little bit more about it, but it started with this. As a tongue-in-cheek, sort of a humorous way, I'm from Minnesota. We don't know how to tell a joke in Minnesota, so we have to be very subtle in our humor, and we think it's very funny, but nobody else gets the joke. But this is a joke, essentially, sort of against my friends who think 50 lesions is all a dental student can learn. And we only found in those 24,000 mouths 53 different lesions. So at least you ought to know those 53 lesions, be able to have an image of what they are in your mind, know what to do, sort of what the biological behavior is. We know all of that pretty well in oral pathology. But I called it the 53 most common oral lesions. It's a PowerPoint presentation with hyperlinks. So it's like a website, but you have to call it up in PowerPoint. And I've since given it to an oral cancer foundation in Texas. So that's why it's the Jack Clark Foundation. Where can you get a hold of this? You can find this on this disc. I've been passing these out like candy. They're all over the world. There are tens of thousands of these around the world. This is a disc with 3,000 mostly clinical pictures, all of them copyright free. You can do what you want with them. And I will leave a copy of this disc in the school, so each of you can have a copy if you wish. But in this, there are several PowerPoint presentations, hyperlink types of presentations. And you notice the first one, the oldest one on here really, is the 53 most common oral lesions. And let me just give you a little feel for what that is all about. This is how it will come up. And then you get a little field, the copyright page just says you can do what you want with this. I've got some sponsors, some of them from West Virginia because that's where I was when I started, others in Texas and around the US. You can learn a little bit about me. But you can go to the prevalence list, and you can learn about the tables, these lists, or you can go to the tables and just go down the list. If you want to see what is the 25th most common lesion, guess what it is? Squamous cell carcinoma. The 25th most common oral lesion found in a bunch of random people who represent about 3/4 of an entire adult population in these communities was squamous cell carcinoma, previously undiagnosed. Just keep that in mind. Of course, you'd have to go through a lot. You have to go through these 25,000 people to find these. But that's one thing you can do. So if you see a lesion you want to see some pictures of, click on that. Here are some pictures of mucoseals. If you want to see other pictures of mucoseals, I tell you that there are 7 pages of mucoseals here. If you want to, this is my subtle way of getting a bunch of extra lesions listed. If you want to know what the differential diagnosis is, and that is a term I've been using too much, so I've shifted recently to lookalike lesions. If you want to see what lookalike lesions are for mucosal, here we have 4 pages of those. So that's one way to look at this. Another is to just go through the list by frequency. Here's number 1, here's number 2, here's number 3, here's number 4. You can go through the whole list. But probably the most fruitful way to do this is to do it the way your mind should be working. When you look at a lesion, you have to be able to describe it to me very, very well over the phone. If I get a picture, that's fine, but your brain has to work well enough to know all the descriptive terms and know what lesions fit into each category. And these are the broad categories that I put together back when I was very young, and they seem to have held up over the years. If we look at lumps and bumps, or let's look at some white lesions. Here we have, at the top part of the page, gives you all the white lesions that we found in these 24,000 mouths. If you want to see what smokeless tobacco can do, then go ahead and look at that. And then I added a whole bunch of extra lesions, another 80 lesions or so. And these are not lesions that we found, but you would have thought geographic tongue, oh wait, geographic tongue is on that list, okay. I have a listing of less common lesions, and here's the same thing, but these were not found in our 24,000 mouths. So here you can go to, if you think you've got somebody with syphilis, you can go to see what some of those syphilitic lesions look like. So that's yours. And that means that you don't have to listen to me anymore. There we go. Okay, so what are these lesions? I've given you a bit of a list, and fortunately, for me, because I love to talk about it, the number one entity is leukoplakia. Leukoplakia is something that is pretty odd, but leukoplakia has a long and really, really controversial history. My master's thesis was a prevalence study of oral leukoplakia, and my advisor would not allow me to use the word leukoplakia. I mean, it's just a word that says white patch. But I was not allowed to use it, and when I asked him, well, what word should I use, he said, make one up. So on my thesis, it says the prevalence of non-specific white keratosis. It's a very bad word, but when I finally published the thesis, leukoplakia was back in. Leukoplakia goes back a long, long time, but really in written history, it goes back to the 1870s. And really, leukoplakia, as we knew it in those days, was a very, very prominent entity. It covered the entire tongue. The tongue became very stiff because the tongue was full of granulomas. And this was found in syphilis, the third stage of syphilis. The third stage of syphilis leads to a lot of degenerative changes. There are very few microorganisms, and almost all of the damage is done by your own body, your immune system attacking, trying to get rid of those few little bugs that are left behind. Syphilitic glossitis eventually leads about 1 in 4 times to a cancer of the tongue. And this was, when I was young, this was the disease that everybody worried about. This is the one that everybody had to find out about. And so syphilitic glossitis really has gone in my lifetime from being a disease that everybody had to know about to the point where for the 4th edition, I know my co-authors are wondering if they should even mention it, because it's not really seen much in at least our hemisphere. But it is seen in in the Asian world, so I think they'll probably keep it in. Well, that's where leukoplakia got started. So here, the very first leukoplakia had a 25% chance of going on to malignancy. If you had a 25% chance of going on to malignancy in your mouth, what would you do about it? You'd want it cut out. But how do you cut out something that covers an entire tongue and it's bilateral? You can do it. There was a very frightening study about 7 years ago, and an Italian oral surgeon looked at all the papers that cut out leukoplakia and then followed those people. And it did not make a difference, according to the evidence base. It did not make a difference whether you cut the leukoplakia out or not. Imagine that, what kind of a disease that would be. So that leaves us all in a dilemma. As a matter of fact, I was on a panel for WHO around that same time, and there was an oral cancer congress, international congress in London immediately after. And we had to go on stage and explain that, you know, it doesn't make any difference if you cut out leukoplakia according to the literature. And one guy stood up and looked at my friend Eddie Odell, he's the premier oral pathologist in England, and said, Eddie, if this was in your wife, what would you do? And he hemmed and hawed, and he said, I'd want it cut out. So that's where it all started, and that's where we are now. And unfortunately, it's the kind of thing, if you just leave it alone, there is that 25% chance. And so we have to keep cutting these lesions out. I have a patient who's had over 45 biopsies over a 22-year period. She's back in West Virginia. She's had 4 oral cancers biopsied during that time. And she's not mutilated. She's still surviving. The only reason she's alive and well today is because this oral surgeon decided, okay, I'll give you free biopsies just as long as you come in every 2 months. So she's been going to him every 2 months for a lifetime. Well, the leukoplakia has led to something, you don't even think this is controversy, but when I was young, the word precancer was even controversy. Because in medicine, they were thinking, that their definition was, here's a benign lesion, but it's going to go on to cancer. And this is an entity that is guaranteed to go on to cancer. And that means if you diagnose it in your patient, you better do something. I mean, fortunately in dentistry, we have the oral surgeons, so we can always send the people into the oral surgery world, but they don't even know what to do with it. But dentistry was, and ENT people were really the people who changed the definition of the word precancer. We've done a lot in this whole field of precancer because of this disease, leukoplakia. We changed the definition back in the 40s, even before my time in oral path, and we changed it to mean this is a benign lesion that has a higher than normal chance of going on to cancer. That gives us a little bit of leeway, but it's also kind of a scary prospect when we're clinical people. Well, over the years, all of these have been in that precancer category. Nobody today would think a papilloma would be going on to cancer, and yet we know that the HPV virus, papillomavirus, is the #1 cause of cancer of the throat. We've just accepted that within the last 2 years. And so maybe there is something going on with papillomas. Well, these are all things that have been called precancers, and in the leukoplakia category, there was a time not so long ago, just as I said, around World War II, we started changing all of that. There was a time when any white patch in the mouth was called leukoplakia. And papillomas were the quintessential white patch in the mouth. They split off a long time ago. Only about 20 years ago, we have this entity called frictional keratosis. And we have another entity that is a precancer that's similar to this. It's called smokeless tobacco keratosis. And I even went back in 1980 before our national board, or our national academy, and the title of my talk was Smokeless Tobacco Keratosis is not leukoplakia. Because leukoplakia has this funny definition. I don't know if you appreciate that, but we don't have any definition like it anywhere else in dentistry. It is a disease that has a clinical appearance like every other disease. It's a white patch. It doesn't peel off, so you know it's not candida. You can't give it a cause other than tobacco, and now we're getting kind of confusing. But the kicker is this last part. You cannot give it another diagnosis. How many other diseases have a name that depends on you not being able to give another diagnosis? You know what that means for you? That means you have to know very well every single white lesion that occurs in the mouth, because you have to rule all those out before you can call something leukoplakia. And frictional keratosis is another term that we've used, thank God, more with great success frequently, because so many things in the mouth are nothing but calluses. They're just white patches from rubbing against teeth. And there is no malignant potential. Nicotine palatinus, about, again, 20 years ago, we thought that was a precancer. People actually had very severe nightmares if they were diagnosed with nicotine palatinus. The vice president of our medical center came to me in panic because he was a pipe smoker and he'd just been diagnosed with nicotine palatinus. And then a friend of mine in Pittsburgh wrote a paper. She had a classic nicotine palatinus in this woman, older woman from England who'd never smoked, never used tobacco at all. And through detective work, she determined that it was the heat from very hot tea that was producing her nicotine palatinus. So because of one paper, the rest of us changed our mind, because we knew this was not a precancer. None of us saw any cancers come out of this. Even though it's a smoke-related entity, it's a lesion created by the temperature of the smoke rather than the carcinogens. Epulus fissuratum on the edge of a denture was still 25 years ago considered to be a pre-malignancy. Hairy leukoplakia came along, and it's not a true leukoplakia. It's never been a pre-malignancy, but it has the word leukoplakia. These ones with question marks are what we're dealing with today. 4 years ago, somebody said, if you see this particular lesion, I'll show you this, alveolar keratosis is the name that you should give it. And what did that do? It's a white patch, but it's in a special location, has a special appearance. If it does that, if it has that, you call it something else. That means it's not precancerous. It's not in the leukoplakia category. So the oral precancer realm has really been influenced worldwide by the dentists mostly in the US and Europe. But still, it's pretty well accepted now, this whole idea of precancers. There's another concept called field cancerization that really was started by dentistry and ENT, because the smoke affects all of these sites, the throat, the mouth, the nose, and all of them seem to be equally susceptible to development of cancer. So another thing that has come out of the oral cancer and throat cancer experience has been this concept of multi-hits. Here we go, multi-hits. If you have multiple hits, if you can have a cancer, maybe I'm somebody who's got a genetic susceptibility to this stuff, but then I have to be smoking. Otherwise, I'll never really develop my oral cancer. I have to have something else. And maybe smoking changes my DNA a little bit more. I need something else, so I drink a lot. And that changes it a little more. And right now, we're probably thinking before you can become an oral cancer, you have to go through probably 8 or 9 different steps. And it could be stopped at any of those steps. And that is a field of extremely powerful research right now, looking for markers that will tell us that this is a step. If we can do something at that level, we can keep this cell from going on to become something worse. But of course, we've all known forever that tobacco is the #1 cause of this particular precancer, just as it is a cause of leukoplakia, of lung cancer. And again, you might not appreciate this, but the mouth has more precancers than any other part of the body. That's why so much research has come out of our stuff. We use the word leukoplakia. We took it because of that tongue lesion, but it was really taken over by the cervical people, the GYN docs. They were using leukoplakia when I was young to describe precancers of the uterine cervix. They don't even have that name anymore. GYN does not, dentistry is the only area where the word leukoplakia is still in use. What do you call it if you find a white patch on the cervix? Call it an HPV lesion, because HPV has been so strongly tied to that. We're trying to do that. HPV-16 seems to be the biggest culprit. We're trying desperately hard to do this, and we already have commercially available products that will test for these viruses in our patients' saliva, but we haven't made the connection yet. In the throat, we've got that connection, but we haven't made it with oral cancer. Tobacco chewing is something we've known about for a long time because of the way tobacco is chewed in India and in some South American countries as well. It's a little different, quite different from the way tobacco is chewed in the southern United States. As a matter of fact, tobacco, I wrote a paper from when I was the dental director. I did an incidence study of oral cancer in West Virginia, because that was the #1 state in America for tobacco chewing and had been for centuries. And it turned out that we had less oral cancer in West Virginia than the national average. Tobacco chewing we think of as a precancer. It does produce cancer, but it is a much lower level than smoking tobacco. And there are some people who try to encourage, if somebody cannot quit smoking, they'll encourage them to start chewing. That's a big controversy in our country right now. I've talked to you about syphilitic glossitis. Sun damage on the skin or in the mouth only really affects the lower lip, so that is certainly a cause for that particular site. We've got some problem with our ENT colleagues, head and neck, ear, nose, and throat docs, because in their literature they think that using heavy-duty mouthwash produces leukoplakia, but it's a white chemical burn. I don't know how many of you have seen it, but we don't think that's leukoplakia at all. We just haven't studied it much ourselves. And then there are lots of diseases, mostly lichen planus and lupus, that do produce lesions that cause a lot of turnover in the epithelium, and because of all the new cells that are being produced, they do have an increased risk of oral cancer. Yeah.
What about marijuana consumption?
The question is, what about marijuana? Well, one of the lectures I've given all day on, I call it the abused mouth. It's all of the things that happen to the oral environment from street drugs and prescriptions and habits that people have. And so I happen to know about that. And there is one paper that shows an increased risk of tongue cancer from marijuana, but it's just one paper and the numbers aren't very high or very, very big. So I think we need like 50 more papers before we can say it's a risk. There aren't too many marijuana smokers who smoke to the level of a cigarette smoker. That's the problem. I mean, there are a lot of them, but not enough for a big population study. So I'm not sure if we'll ever answer that. One of the things I found out when I moved to Houston is cocaine can produce a leukoplakia. And as a matter of fact, I published that a few years back. I called it cocaine keratosis because I don't think it's a precancer. I didn't know that people put cocaine and powdered crack up under their upper lip. I was just too dumb to know that. But now I'm in a big city, and our emergency clinic has maybe 40% of the people go through that clinic are addicted to something. So I've seen a whole bunch of oral changes from that kind of thing. But I think you're still safe with marijuana, if that was a personal question. In Minnesota, we always could tell the farmers because their lower lip was big and puffy, and they had these vertical lines that developed. And then they would get blotchy areas, some areas pink, some areas red, and then some people would develop this leukoplakia on the surface. Others would develop a breakdown ulcer, usually where they kept their cigarette. And you know, we have in our country this sort of a law. It's really a standard of care that if you have an ulcer in the mouth and it's still there two weeks later, then you should biopsy that. We can go a full month without any real problem, but that is a pretty firm rule. You have an ulcer in the mouth and it's been more than a month, you should find out what that is because, of course, squamous cell carcinoma is 1/3 of those are ulcers. And this is a real exception because you can have an ulcer on the lip that lasts for 2 years and it never seems to heal, even if they move the cigarette over to another side. So that is a real issue. But we say that there's about a 6% chance of these kind of lips going on to cancer. In Minnesota, we call them farmer's lips. In the Northeast, they call them sailor's lips. It's all the same phenomenon. But a funny thing happened in some of the work that I have done at the Mayo Clinic in Minnesota. I looked at all of the precancers and cancers of the whole head and neck area going back to 1935. I looked at the original medical records, the original microscopic slides, and it turns out that lip cancer was the most common cancer of the whole head region in 1935. And by 1985, it was gone. There were almost no lip cancers. Now, how can that happen? It's still the same population. And fortunately, I was there so much, I lived in the community, and I would ask people around me, I've got this problem. What do you think happened? And they said, just go drive around and look at the farmers' fields. You'll find that the farmers are in nice big air-conditioned tractors with UV glass protecting them from the light, and there's stereo system going. And in the old days, they were out there with a shovel and a rake, and they were doing the work by hand in the sunlight. And of course, these are Northern European stock people, so they're more susceptible to sun damage anyway. So that was a kind of an interesting phenomenon. We don't see much lip cancer anymore in any part of the country. If you look at the state of Texas, which I just did look at the data, the southern part of Texas has actually less lip cancer than the northern part of Texas. And Texas is a big place, and you would think there'd be some kind of a geographical difference, but it's just the reverse of what I expected. The biggest problem with this is the epithelium becomes really, really thin. And I think it's because we don't have good nutrition. You can see a blood vessel here and here, but we don't have all those tiny little vessels that go off and feed the rest of the tissue. And this is a pink material that is just broken up bits of collagen and elastic fiber. We call it solar elastosis. But that's really what gives you the wrinkles. And that's what, if you put on an anti-aging cream on your face, that increases the fluid content of this material and makes the skin puff up a little bit and you look a little younger. So just want to let you know, you're just treating your solar elastosis when you're treating that. But this is, the epithelium gets so little nutrition that we really have a problem with having epithelium that's able to withstand even the minor trauma of holding a cigarette in one place. So that's, I think, the biggest problem. If you have an ulcer on somebody's lower lip and you want to know is that a cancer or not, the best thing to do is get your fingers on it and feel it. If it's very firm, then for sure get a biopsy. Or if it's got a little bit of a rolled border, for sure get a biopsy. Well, this is a whole field of oral pathology. All of the, I'd say maybe 80% of all of the NIH grants that come out of the Dental Institute really relate to oral cancer and oral precancer. The only NIH grant I've ever had was a oral precancer study. But we're really into a technology age, certainly in the United States. From what I saw yesterday, you're certainly into it here. And there are gadgets that are coming out, and they're coming out probably before they're ready to come out, and the manufacturer wants you as the dentist to buy this product, which is usually a few $1,000s, and find these oral cancers at the earliest stage. And really, the goal is really an honorable and noble goal, but I don't think we're quite there yet. But what we're trying to do is see what's going on just beneath the surface. And let's look at some of that. We had a guy, I studied with him in Denmark. His name was Jens Pinborg. And there's a Pinborg tumor you might be familiar with, some of you who are a little older. And Dr. Pinborg came to the United States when I was a resident back in the early 70s. And he gave a classification of leukoplakias, clinical classification. He said, if it looks like this, the risk of going on to cancer is less. If it looks like this, it's a little higher. If it looks like this, it's higher yet. And do you know that we don't do this often in America, but we laughed at him. I didn't because I had studied with him, but the crowd laughed at him. This is so silly. Even though he had the data to prove it, he had done all kinds of follow-up studies himself. And this was the result of thousands of follow-ups. And now that's exactly what we're using. We're using, for the past 40 years, we have been using his system. So that's a clinical system. That means you have to know exactly what to look for two reasons. Number one, you have to know which ones are going to be bad actors. And number two, you have to know where to do your biopsy. If you've got a large lesion like the one I just had on the screen, you could biopsy 5, 10 different places and not go to the place that has the most likely bad cells, the most likely chance of finding bad cells. So it's a simple system. It's not quite as clean cut in real life, I know, because I've seen thousands of patients with these kinds of precancers myself. But essentially, we start out, every leukoplakia starts out as a thin layer of keratin. And initially, it's kind of grayish looking rather than pure white. It's smooth on the surface, although you can get fissures in it because our environment has very mobile tissues. And if you thicken up the surface a little bit, it has to have some areas of flex. And that's what the fissuring is all about. And if you biopsy anywhere, I don't even recommend biopsying these kinds of leukoplakias, haven't for decades now, because all we ever find is some extra keratin. We might see maybe a few dark cells down below, might see some abnormal tips on these reedy processes, and that's now considered to be not a good sign. But it's not bad enough to even call it mild dysplasia. Those of you who have not had your oral path or oral medicine yet maybe don't realize, but we have dysplasias. Dysplasias are abnormal cells microscopically, and we grade them 1, 2, 3. We actually say mild, moderate, and severe dysplasia. And this doesn't even come to the level of moderate or mild dysplasia. And then as time goes on, it becomes a little more thick. You may have some thin leukoplakia around it, and you may see a little bit of roughness, but by and large, it's fairly smooth on the surface. And that has an increased risk. We're not attaching numbers to it, but if I were to attach a number, I would say the risk of the thin leukoplakia is around 0.5%, and this is up around 3%. And then we start to get really thick and really large lesions, and the risk is increased. And as long as it remains smooth, then it's not nearly as high a risk as if you have rough granular surface changes. This has changed a bit from Pinborg's classification. He died before we really had an additional classification. And that classification says if you have a leukoplakia that is larger than 3 centimeters, or if you have more than 2 leukoplakias in the mouth, then you have a disease that we give a new name to, but it's still a leukoplakia. It's called proliferative verrucous leukoplakia, PVL. And if you have a diagnosis of PVL, that's the diagnosis you guys give. I don't do it. I just tell you what the individual biopsy is showing. But if you give me clinical information that gives me size and multiplicity, I can put a note on the biopsy saying, this is suggestive of PVL. And then I always say clinical correlation is suggested. And that term, clinical correlation, is suggested, meaning that means I'm copying out. I've done my job, now it's up to you to make the final diagnosis. You're used to the biopsy being the final diagnosis, but there are a few diseases, and this is one of them, where the biopsy is only the intermediate diagnosis. So in this one, this would be a PVL lesion just by its size. But even before that, Pinborg would have considered it higher risk than a smaller or less thick lesion. And microscopically, this is all we see. We see some pointed projections, a lot of extra-keratin. We may see some dark cells here and there in the bottom, but most of the time we don't see much dysplasia in these lesions as long as the surface isn't too bumpy. And then we get these irregular changes, almost, well, it's hard to say exactly what it looks like, almost like little sand dunes on the surface. I like to call this granular leukoplakia, but in Europe they call it non-homogeneous leukoplakia, but that has several definitions. But that is a step up, and generally, in my mind at least, if you have a granular leukoplakia, regardless of size, then I'm estimating you have about a 15% or more chance that it's going to go on to cancer. And then you get these areas where you've got pink, totally surrounded by white stuff. It's a pretty simple concept, but if you see that one area of pink that is almost or totally surrounded by white stuff, then you have to put it in a category of speckled leukoplakia, and that has a higher risk yet. That has the highest risk of all. And then whenever you have a leukoplakia, one of the things you have to look for is an actual ulceration, because here we have a lesion that has smooth leukoplakia, it has thick granular leukoplakia, it has speckled leukoplakia, and it already has the malignancy. And certainly if you ever see some reddish-looking material that's rising above the level of the leukoplakia, that has to be biopsied. You cannot let that go. But always get your fingers in and try to see how firm it is, because malignancy in the mouth is a very firm and painless entity. And then when we get into the granular leukoplakia, there's some oddball things. Like in the site here where somebody would be chewing on their cheek, we very frequently, if not usually, find candida embedded. And when we treat these people with diflucan, which is an antifungal that is at the same level in the saliva as in the bloodstream, so you're kind of hitting this lesion from the inside and the outside. When we treat with that, then the level of dysplasia goes down and it often will smooth the surface. Very odd. So if we diagnose one of these in a biopsy, we'll stain for candida, and if it's there, then I put a note, at least on my biopsy report, saying I would wait another 2 months, treat for candida, wait another 2 months and biopsy again, because then we can get a more honest level of dysplasia. The candida, we don't think it really produces dysplasia, but it makes the cells change in a way that we're having trouble confusing it with dysplasia. And candida is a pretty easy thing to diagnose with special stains, but of course we don't see it normally. And you'd think in a specialty that's been around since the 1930s, we would have most of the answers. But here's a new entity that's just popped up in the past 7 or 8 years. We don't know what to do with it. We assume we have been seeing this all along, but we just never were curious enough, or we didn't see enough of them. We don't know why we haven't talked about this. But these are almost mass-like leukoplakias, granular leukoplakia that has little elevations. And it's very well defined, but see how we have some areas that are elevated above the other areas. And we thought maybe this was HPV that gets into the tissue and makes these lumps, but we're not finding it. So we're stuck now with a term, I call it atypical papillary epithelial hyperplasia. You will not find that in our textbook or any textbook, yet every oral pathologist in the world knows that this is an entity, and we all consider it a precancer. We often find dysplastic cells, immature cells in this tissue, but we have no idea what to do with it because not a single person has done a follow-up study. Nobody's got enough cases to do that yet. You don't know this, but all of the oral pathologists and most of the oral medicine docs also worldwide talk to each other every day. We have a list server. It started in America, and when I was young, we had this music called bebop music. Well, this is the bulletin board of oral pathology, so of course we call it bebop. And so we are constantly, people will come up with this and say, has anybody got enough cases to do a follow-up study? And nobody has very many. We've got about 8 in our institution since I've been there. But we're recommending more than conservative removal of these, but we're doing it on a whim. We really have no evidence base for this. And it's kind of scary to be part of a profession that has a lesion like this late in the day. Why haven't we run into this, and why haven't we come up with a definition, a better definition, or at least a name that works for us? We think it's part of the leukoplakia category. We don't know for sure. And I mentioned this alveolar keratosis, AK, 4 years ago. Just out of the blue, somebody did over 1,000 biopsies or looked at over 1,000 biopsies of this little white stuff. You see it, we just see it on the biopsy. You see it as rough leukoplakia, so that would put it in the higher category of risk. But in 1,000 biopsies, they found 1 mild dysplasia. And this oral pathologist's conclusion was that this is not a leukoplakia. We ought to see more bad cells in 1,000 of these than we found. And so I'm going to call this, or recommend we call this, alveolar keratosis. And as I mentioned before, that means it's out of the leukoplakia definition. And that means it's got a biological behavior of its own, not part of the leukoplakia biological behavior. If you think about it, as time has gone on, all these benign and look-alike lesions have spun off of the term leukoplakia. So the leukoplakia we have today in today's studies is totally different from the stuff we had when I was a young person and calling it leukoplakia, because some of the entities that I called leukoplakia no longer would be called that. So it's a moving target trying to do research, clinical research on this. Sometimes we see it extending along the crest of a ridge, not only in the retromolar pad area, but here's the key. If you see it down in the vestibule, then you have to call it leukoplakia. If it remains on the ridge, we think it's a kind of a frictional keratosis. We can't explain it, but we're not worried about it. And we don't think of it as a precancer. That means it's your job again. You can biopsy it, and I'll give you a verruciform hyperkeratosis kind of a diagnosis, but that won't be satisfying to you. There's another entity. In my career, I've given about 20, 21 names to new entities. And it's only because I have a lot of curiosity. Everybody else is doing basic research, looking for molecular markers that will be the thing that will show that a precancer will become a cancer. And I'm just looking at all these other entities, and this is one of those that I found out since I've been to Houston. I told you about cocaine. If you tuck it up under your lip, some people put it back in the mandibular vestibule, way in back where smokeless tobacco would be used also. But if you have an area that is edentulous and you put it in that area above and beyond, this I've only seen in the mandible, it looks as if little rats have been chewing on it. It's a white granular buildup of keratin. So technically we would call it a leukoplakia, granular leukoplakia. But then we have these open wounds in here, like rats have been chewing on it. And I've run into maybe a dozen of these so far. And we happen to have the head of our urgent care clinic, our emergency clinic, is the kind of guy that can talk to people and get them to tell them, well, yeah, I get my drugs on the corner of 5th and Main, and Charlie gave me a bad batch last week. He gets them to tell them everything about their drug habits. I can't do that. They'll tell me, oh, I don't use any drugs. And then I send him over. And he comes back and said, oh, yeah, they keep cocaine in that place. And they use cocaine maybe 7 times a day in that spot. So this is maybe a cocaine keratosis, similar to what I mentioned before, but because of these little chronic painless ulcers, really, I've called it cocaine excoriation, just because that's the word that we use if you scratch your skin too much. So that's a whole different ballgame. That's another entity that's a white patch that I don't think will ever be considered to be part of the leukoplakia or precancer situation. So what do you do if you have a patient who's got thin leukoplakia, it's got thick leukoplakia, it's got thick, lumpy, bumpy, granular leukoplakia, and then it's also got these white patches or speckled leukoplakia? Where do you do your biopsy? I would avoid the thin stuff. I'd avoid the thin, smooth stuff and go for the really thick stuff, and especially any red areas that are completely or partially surrounded by white. I would avoid the thin stuff. I'd avoid the thin, smooth stuff and go for the really thick stuff, and especially any red areas that are completely or partially surrounded by white. And if it's pink, that's still susceptible, but if it's red, it's an even higher risk. And I would recommend doing multiple biopsies, probably at least 3 in a lesion such as this. Because if you start biopsying over here, you're going to give that patient a very false confidence. They're going to go home saying, oh, I'm fine. It looks funny, but I'm fine. And in fact, they won't be fine. And we've got some new technologies I'll talk about, I think, before the break, that can help us to look at these entities as well. If you biopsy here, you're going to just get hyperkeratosis. If you biopsy here, you're probably going to find these abnormal cells down deep and maybe all the way up to the top. So what would you do with this entity? It's bigger than 3 centimeters, so we've already put it in that category of PVL, proliferative verrucous leukoplakia. And speckled leukoplakia is a term Pinborg would have used for this. So even with his category, we've got a high risk. He would have said that there's at least a 20% chance that this will go on to cancer. What is your risk of going on to cancer if you are diagnosed? Remember, you're doing the PVL diagnosis. You write in your chart, this patient has PVL. What do you suppose the risk would be for that? Anybody have such a patient? The risk is 80 to 100% that they will develop a malignancy in their mouth. And these are people who are non-smokers usually, no alcohol consumption of any to speak of. We don't know what produces PVL. We don't even know what to do about it. In this patient, you're going to remove a great deal of mucosal tissue. I think what we did is we removed it in parts, or the oral surgery department decided to take it out in about 5 different parts, let it heal in one area. And within 6 months after they removed an area, here these little white dots are creeping up again, and it's coming back. So remember that one patient I mentioned, after 22 years, 45 biopsies, 4 cancers. She's not disfigured. She still has all of her function in her mouth. Those cancers were found at half a centimeter size, and she was part of her follow-up. Every day she got her fingers in there and tried to feel for a little area of induration or a little raised spot, because with PVL, as the name might imply, verruciform, remember verrucous means pointed projections. It has a particular, the cancers that develop in that have a particular propensity to be little bumpy masses. So they're a little easier to see than in other kinds of leukoplakias. And if that isn't bad enough, remember I told you the red parts of those speckled leukoplakias are really the worst part? If you don't have any of the white patch and you only have the red, that is, other than PVL, that is the highest risk. And as a matter of fact, we call it red patch, erythroplakia, and about 90% of the biopsies from erythroplakia are either already carcinoma in situ or just barely invasive carcinoma or severe dysplasia. They're very severe lesions. Well, I gave a talk, well, it'll be my last comment, I guess, before the break, but I gave a talk in Nice a while back, before our book came out, and it was an ENT World Congress on head and neck cancer. And they asked me to talk about this whole precancer concept for the mouth as well as the throat. And I was coming back, and I had just given this talk, and everything was in my head pretty well, and doesn't always sit in my head pretty well, so that was a good thing. And I was coming back on an overnight flight. Turned out to be the very last flight that Pan Am Airlines ever had, was the Nice 747 coming back to New York. And we had 6 passengers on that plane, 14 crew and 6 passengers. And I decided I was going to make a drawing of what happens, what to look for, going from normal to more and more severe. And I started with a piece of paper over here, and the stewardess noticed when I got here I didn't have enough room on my tray. So she actually went and got a pine board on a 747, about 6 feet long, and it's the board they use to carry people out through the aisle when they have a heart attack or something. And that's what I drew. She gave me some tape, and I just taped a bunch of papers together. And by the time I got back, I had this drawing done, and these little circles represent abnormal or dysplastic cells. And I just gave it to a medical artist who covered it with India ink or traced it in India ink. But this really, I think, is just a summary of what I've just said. We start out with thin, and we get to the thicker areas, and we're getting to the thicker and lumpy, bumpy areas. Sometimes we have candida involved in that. And we see more and more of these bad cells as we go toward your right. And after a while, the cells are too immature to even make keratin, so we get these little patches of pink and red. And then eventually we get to a point that's more red than white, maybe completely red. And you just have an increasing risk as you go on. And that's the image you have to keep in your mind. It's in our textbook as well. If you know these changes, then you can make an estimate of whether, you don't have to put a number to it, but you can say that this has a higher risk than another kind of lesion. And I've already talked about PVL, so I'll mention this one was not only because of the large size, but it was PVL because there were 2 lesions, I think, on the other side. And there was one paper with a 50% risk, but it only had 7 people followed. Most of us are in the 80 to 100% risk of going on to cancer. Oh, this is, by the way, one of the most scary things that I read in a paper in recent times. There was an ENT paper that biopsied if people had dysplasia or cancer, that if they had cancer or PVL, then they biopsied normal-looking tissue. And 40% of the time, they found dysplastic cells. And I don't know what you do with something like that. That's maybe all part of this field cancerization, where the whole field is equally susceptible because of tobacco or some reason that we don't know about. So what I'll do when we come back is, well, wait, this is, you look at this. Where is the cancer? I saw this patient 5 years later, and he had a malignancy. He wouldn't come back for follow-up. Actually, this was Dr. Pinborg's patient. Everybody have an image of where you think the cancer is going to develop? This is 5 years later. And if you look at it, that's where the biggest speckling. Remember that concept. There's not enough maturity in those cells to make keratin. And then I don't think we have to talk about the AIDS kind of leukoplakia. We almost never see that anymore.